middle rhythm strip, I mean the middle lead, if you see nice QRSs ongoing, and then starting from the first and third lead, some artifact, which is similar looking, starting. Again, a little less artifact in the middle strip. You still see nice QRSs at the expected time. Okay, you're not able to see the P waves because of artifact, but it doesn't matter because you see it initially, and it's the same QRSs. And therefore, while you're having the same QRS, remember that these are simultaneous leads, right? So the QRS here, if there's a QRS here and QRS here, and there's nothing in between, so what you see in the other leads is the same. So it's simultaneous. Therefore, what you see here actually is artifact, and it's the same way like we saw here actually. And when we, again, when we look at it towards the end, it would look the same. This is another area again, the same artifact starting in a different way. Again, we can clearly see from the middle strip that actually it is, sinus. And actually when we continue, same here. The big artifact in the first and third lead, especially first one, actually kind of, blocking the middle rhythm strip. But if you pay attention, the same QRSs, like these narrow things are the QRSs are continuing. Again, look at different areas and make sure what you're seeing is not VT. Of course, it would make a big difference whether this is VT or not, right? So basically this is artifact, okay? So as I said, this is an example of another thing. As you see, there is a, most likely, we don't know, we don't see in detail, but most likely sinus rhythm, and there is an arrhythmia starting here, right? So always when you read a halter, or when somebody gives you a halter, like of an event, it could be SVT, VT, whatever, doesn't matter, like the other one I just showed you, you need to actually ask for the beginning of the event. Like here, with this yellow, I am zooming. Actually, it doesn't show here, but I'm just pointing to this important fact that seeing the onset and offset of any type of arrhythmia is very important. It's a very common problem that we see halters that are presented to us saying that SVT, okay, and a lot of times you see T waves right after T wave, a P wave. To me, it's actually a very obvious sinus tachycardia. But to be able to say for sure, I always look for, okay, where is the beginning of the strip or event? Is the gradual change or not? Is the offset gradual or not? So that I'm able to say for sure it's sinus or not. And a lot of times it's missing, but that's what you need to focus. So we need to know how an arrhythmia starts. Like in this case, this is a non-sustained arrhythmia, right? So let's get your views about this, what you see. Again, if I can get some input, I will help out. Okay, I can focus a little bit for you to see better, maybe. Okay, so non-sustained arrhythmia. What type of arrhythmia we see here? Again, it's from a 3-lead halter, as you see, right? Okay, so far, all right. So far, I think few people are saying this is SVT. Okay, any other opinion? Reentrant SVT, okay. Short RP SVT, good. Yeah, so nobody's saying actually VT, I guess, right? So basically it's a non-sustained, right? Non-sustained SVT. And before and after, this is, you see the sinus. So the way it starts, if you look at it, we need to always try to focus on how it starts. Most likely, as you see, there's a little notch here on the first here lead and the third one, hard to see on the middle one. So a PAC actually starts this tachycardia. And if you focus, you never have, I'm zooming as you see, you never have an ST segment like this. You don't have that type of notch. So that's a P wave, okay? Okay, you don't have to see it in all leads. Middle lead is hard to see, but the third one, again, there's some deflection here. So that's your P wave actually. And since during SVT, if you look at the RR interval, it is actually before the middle. So kind of soon after the QRS, it's a short RP SVT. But let's see, so this is how it started, like a PAC started this tachycardia. So likely to be reentrant SVT as it was suggested by one of you. And how it ends, right? Okay, here you go, how it ends. All right, so I think there's a chat window. Some people are putting it in question area. So put your comments in the chat window directly. So how it ends? It ends with an A, right? How does this change actually? Like what does it tell us? Like if it ends with an A or P wave, like this, again, you see it here. How does it help us in terms of the type of SVT? So short RP SVTs could be AV node reentry tachycardia, right? It could be different types of AV node reentry tachycardia, depending on how short it is. And most commonly in a child, it would be actually accessory pathway, right? So yeah, there are a few comments already. The only thing really pretty much it rules out is focal atrial tachycardia. It would be very unusual for a P wave not to conduct in a focal atrial tachycardia and stop like this. So if you see a P wave as the last event, in the focal atrial tachycardia, it should normally conduct, right? And then stop. So therefore, the last thing you should see is a QRS actually in focal atrial tachycardia. If you see a P wave, then you kind of rule out, pretty much rule out. It will be extreme, cases. Sometimes you can have Venkeba, during tachycardia. It stops the same time, but it's too much coincidence. So usually, in general speaking, you can easily say if your SVT ends with a P wave, it is actually not focal atrial tachycardia. So it's so important to see the onset and basically termination of arrhythmias, how things occur. All right. So we are switching to a 12-lead ECG. And okay, like to get your comments. I just want to make sure, the voice, the ECGs, the quality of the images are okay. If a few people can comment. Okay, good. So, okay, waiting for your comments. There's already one person saying, few people actually saying it's possibly Brugada, right? So they're saying Brugada because of this deflection in V1, right? I mean, if you look at this, V1 and V2, looks like a bundle branch block, right bundle or incomplete right bundle. So why are they calling it Brugada? Like, why are they not calling it right bundle? So the first thing to do is you need to pay attention to actually rest of the QRSs. If you look at the left precordials, the V5, V6, there's no S wave. If you typically have a right bundle or incomplete right bundle, you should have some sort of S wave in V5, V6. On the contrary, here, what you see, is a very, very narrow QRS, right? So, but still, I mean, one can be misled. So this is the point of this is like, if you are able to put these leads, and our online ECG system allows this, I think most online ECG systems should allow it. I like to actually switch to 12 lead view. You can easily do that. And when you switch to 12 lead view, just put a line, from the end of what you think that looks like QRS, okay? You will see that the right-sided precordials, this thing that looks like a R prime, actually is not R really, because it's really ending much earlier. I think I have a few more examples. Okay, this is a different one. Again, so therefore this is actually an ST elevation, very typical for Brugada. Okay, it's very mild, but it's obvious. As you see, the QRSs are much narrow. Whereas, like this patient is another patient, okay? Look at V1. Again, you have this bundle branch block appearance. And look at left precordials. Look how the deep and wide S waves are like, right? I mean, this is what you would expect in right bundle branch block. And again, when you put your cursor where you think the QRS ends, it's pretty much the same. There may be a small difference, but it's pretty much the same throughout all precordials, again, compared to this one. This is how you can actually differentiate from right bundle. if you are not sure. So again, this is another example. As you see, very nice narrow QRSs on the left side. And especially V1 is a pretty remarkable Brugada sign, okay? Again, another patient, this is much more obvious than the others. Look at V1, look at V2, and especially V3, you know, almost you don't see where, you know, it's ending, right? So you cannot call this right bundle. It's definitely a Brugada sign. But sometimes people are misled, you know, that's why just put your cursor, like shown here, and see what happens on the left side, and you will see that actually it's not part of the QRS. Okay. So, okay, next one again is a 3-lead Holter. I don't know. I usually mention the age of this these patients, but let's make this one a 3-year-old. Okay, 3-year-old. And okay, what do you think about what you see on this rhythm strip? Yes. Any comments? Okay. I'm waiting. Long QT. Okay. 2-to-1 block. Focal atrial tachycardia with AV block. Complete heart block. Bradycardia with 2-to-1 block. Okay. Good, because you know, the reason I'm saying good is all is wrong, but you know, that's the aim of these lectures, right? I need to know what you're thinking so I can try to explain why it's not that, right? So first of all, let's look at, for example, the comments, right? Long QT. Okay, for QT we need to measure, but the rate is about 60, right? So let's measure like approximately it's 10, 11. Okay, if it's 11, it would be 440 millisecond. Maybe it's 450, 460. Hard to say here, you know, for sure. Okay, but you know, looks like, okay, 12, maybe borderline, a little bit prolonged. But the issue here is really the rhythm. But let's say it was long QT, doesn't matter. And could it have been 2-to-1 AV block? Of course. And some people said bradycardia with 2-to-1 AV block already. So again, you know, one of the things that you need to remember, AV node has nothing to do with the sinus node. Meaning, if the problem is AV block, right, and there's no problem with the sinus node, and let's say it's 2-to-1 AV block, when you mean 2-to-1, that means 2 sinus P waves. When you look at two back-to-back 2 sinus P waves, alternating ones do not conduct, right? That's what 2-to-1 AV block is. In 2-to-1 AV block, you don't have like PACs. What you have is actually all sinus, but one of them do not conduct, okay? So let's look at this. This is P wave, okay? We assume this is sinus, okay? Like here. But then I'm sure all of you noticed, that's why you're calling it 2-to-1. That's not a whole T wave. I mean, look at this. There is a P wave here, right? Okay, and first of all, the shape is different, right? Plus, it's much early. Like, look at this PP interval compared to, like, if this is P, and it is P, because coming in the ST segment, it's changing the shape significantly. And this is a different P, but not only different, but, you know, this is short, this is long, very long. This is short, this is very long. Basically, what you're having is an early P coming early, and it's not sinus. So what do we call it? We call it PAC, right? So it's a premature atrial contraction. So basically, it's a PAC. So therefore, it's not sinus. So you cannot call this 2-to-1 AV block. To call it 2-to-1 AV block, all P waves should have been the same. It should have been sinus, right? Or whatever the baseline rhythm is. So this is actually not that. Okay, how does it explain then? Okay, this is atrial by Gemini, right? Because every other beat is PAC, but they don't conduct, right? So still, is there a problem with the AV node? Why this P conducts, but this doesn't conduct? And already a comment is made. Maybe you are also watching the same thing, the chat, right? So it is so early, right? The P wave is so early that the AV node is still not ready, still refractory, and it doesn't conduct. So therefore, it's actually just a temporary issue. It's not an issue with the AV node. It's a physiological issue. If the AV node is refractory, if the P wave comes too early, it may not conduct. This is not a problem. So there's no AV block problem with this patient. What we call this is a PAC with block. Or you can also call it non-conducted atrial bigamy, like one of our colleagues mentioned. But to make it more simple and to for people to understand, I say PAC with block, and it's an atrial bigamy, right? So okay, that explains why it doesn't conduct. So therefore, there's no AV block. We have PACs, they are in atrial bigamy, they come every other, and then it doesn't conduct. Isn't there another issue? Okay, this doesn't conduct, okay, therefore no problem with the AV node, but isn't there another issue with this patient? Just looking at in general, what do you think? Like this 3-year-old, why is it slow? That's my question. You see the rate is 65 and it's quite bradycardic for a 3-year-old. So why is it slow? And a lot of times these type of patients we see in newborns also, in ICU consults us, right, or infants, they actually, the reason is bradycardia. And because sinus node is reset, right? So as it's mentioned, so what happens actually, okay, the AV node, we explained that, why it's not conducting. But what happens to sinus nodes? If this P wave was not here, if there was no PAC here, the sinus would come earlier time, probably at a more reasonable rate for this 3-year-old. But this PAC basically resets the sinus node. Basically, it enters the sinus node, resets, so P wave for sinus has a new timing, okay? That's why next P wave for sinus comes later. So this P wave actually affects the sinus node, this PAC, and resets it, and that's why your end result is bradycardia. So when they consult these patients, they expect us to use something to accelerate the rate or do pacemaker or something. We, on the contrary, we use antiarrhythmics like flecainide or whatever you want to use. I usually prefer, like these patients, either beta blocker or flecainide. But and then we basically aim to get rid of these PACs. And if you're able to block them, again, flecainide. Some people, if you don't have it, you can use propafenone, I guess. If you can block it, then you will see that the sinus will accelerate. Actually, by using an antiarrhythmic, you will accelerate this rhythm. And it is very common presentation, actually. We see this relatively commonly. So the question, is there a non-conducting P wave at the end of the T wave? Not really. It's, yes, there's a notch. Otherwise, we will have to call it like a double PAC, right? To me, most likely it's artifact because it's not consistent. But that would be possible. I mean, you can have like a very fast atrial flutter type. If you look at this, T wave versus here, it might be artifact, I think. I don't think we can say for sure. It may be a notch of the T wave also. But the big PAC is like the one comes after the QRS. Good. So that's the point with this slide. Let me see where we are. I can't see which slide we are actually focusing on. So we did this one. All right. So next one, I just called it patient X. That probably means there's few slides. So what do you see in this actually slide? Again, a 3-lead Holter. Mostly it's sinus, but right, it's irregular. Why is it irregular? Okay. So junctional rhythm, PJC, a few comments. Normal sinus rhythm with vesicular PVCs. Looks sinus. In general, it's sinus, yes, but as you see, there are some early beats, right? That's why people are, calling it a little differently. So let's look at it from beginning. Here, we don't see the onset too much, but focus on the ST segment. It's a very clean, first of all, strip. And interestingly, there's a notch on all 3 leads, you know, in the ST segment. Just pay attention to this, but we don't see the beginning, so don't make too much out of it. Then you have sinus, 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 a little bit sinus arrhythmia. And then that's the thing that comes early, right? So it looks almost the same. That's why you're calling it PJC, right? Okay, but we have, why you call it PJC? Because it's such a clean rhythm strip and you don't see a P wave, right? So the possibility is something coming early with the same QRS, obviously it's PJC. And then let's continue for now, sinus. And here, what is this one? What do you think about this one? It's a little strange, right? This is the patient's normal PR interval, but this one looks a little different. So P wave here is kind of cut with the QRS, right? So fusion, fusion between what? Between what and what? P wave and PVC. Okay. Yeah, well, I mean, P wave and the whatever, right? So let's go back to this one. So you called it PJC. To call it a PJC, it has to be the same QRS, okay? If you look at this QRS, it is slightly different. And especially the middle one, look at this one, okay? This, because of the lower QRS, you have difficulty seeing maybe, but you know, the shape of this QRS is different. Okay, it's a small difference, but it is different. And look at this one again, same. Look at this, these two are the same. Basically, it's slightly different. So I don't think we should call it PJC. We should probably call it PVC. And here what's happening is actually PVC again. That time it comes a little later, comes right after the P wave. So it looks like it's conducting, but it's not conducting actually. It's just coincidence. That's why they call it fusion. But some of you called it fusion, but basically this P is not conducting. And you know how this short, I mean, really narrow looking thing we're calling, you know, a PJC, not PVC, not PJC, because the shape is different. The fascicular PVCs can be like that actually. So, but when you have suspicion, get 12 lead, okay? So this is same patient, I think. All right, so I think we should have the sample. Okay, when you get 12 lead, and especially if you have a 12 lead halter, or if you can get a longer strip, you will be able to differentiate. Again, you know, look at this QRSs. In some leads, it looks so similar, but some leads, it looks so different. Like look at V1 and lead 1, for example, right? So, but if you look at lead 2, you may be misled, okay? So therefore, if you look at it here, this yellow area actually is what you see in 12 lead halter here. So this thing, it actually is this early beat. See in V1, V2, V3, the shape is different. It's almost like looking like incomplete right bundle, very narrow, with actually QRS is positive looking, you know, on the plus side in inferior lead. So where is this PVC coming from? Most likely. We can tell PVCs usually by looking at the morphology in most patients. That's also important in assessing a halter. Of course, if you have a 12 lead halter. Basically, it's a fascicular because it's very narrow, right? It is left side, left fascicular, and actually it's coming from left anterior fascicle. If you have left anterior fascicular PVC, it's like that. It's almost like incomplete right bundle, very narrow. And the QRSs are positive, kind of right axis in inferior leads. If it was negative on all 3 leads, then it would be left posterior fascicle actually. So that's a fascicular PVC, okay? I think we switched to another patient. All right, this is another patient. Again, I'd like to hear your comments. Sinus and then something happening. Looks like I think that would be easy, right? What do you think, what you see on the screen? It looks same or different? Different, right? Again, if you look at the middle lead, especially, it's a little different. So it's a PVC, and we don't see a P wave. They come at different timing. Okay, good. Let's look at the next rhythm strip, same patient. Okay, again. Looks like there's sinus node reset somewhere here. Again, good. PVC, right? We agree. Next patient. I mean, sorry, not next patient. Next page. You see the PVCs. So far, they look isolated, right? Okay. Next one. So what am I trying to show here? Like these are PVCs, right? And they look similar. Okay. I think we agree. And why do I look at these, you know, this view? Like I'm trying to unzoom, you know, kind of full disclosure kind of view. So what did you notice here, like so far? How would you comment so far with what you have seen? We have PVCs. Of course, we don't know numbers or anything. Just with what you see PVCs. They are uniform or unifocal, right? Any other comment you can make with these 4 slides? 1 slide, 2, 3, 4. Any other comment you can make? Yeah, of course, no couplets. They are isolated. They are not multiform. And yes, actually, this comment I was waiting for. Seems like they're suppressing with sinus tachycardia, right? So actually, when you see PVCs in a Holter, there are things that you need to pay attention. And for that, you need to go to different areas of the Holter. You cannot just say, okay, this patient has 2% PVCs, 5% PVCs. You need to say a lot of things about them. This is one of them, actually. So when you see a PVC in a Holter, what things do you watch for? First of all, is that a PVC? You know, we just showed some that didn't look like PVC, but it was a PVC actually, and vice versa is also possible. So is that a PVC? First of all, make sure it's a PVC. Of course, you know, we all pay attention to frequency. If it's, you know, rare, if it's frequent, it's very frequent, like more than 10%. Are they uniform or multiform, right? If you are able to get it, not every center has it. I always work with 12-lead Holters. I like to get 12-lead Holters in these patients because it tells me a lot about detailed morphology, like the one that I just showed you. I'm able to say it's coming from left anterior fascicle. It has a lot of meaning to me. You know, there would be something different. Plus, I'm able to see changes in the ST, T waves, things like that, you know. So 12-lead Holter, if possible, is nice to assess the PVCs. But if not, you can, you know, get longer 12-lead rhythm strips to look at the morphology. That's also possible. But for that, you may need to catch the PVC in time. Whether there's a couplet or not, right? Or VT or not. VT is more than 3 successive beats, right? What is a coupling interval? So, I mean, I treat sometimes patients who have few, you know, 3, 4 couplets because they are so closely coupled. They are so fast, okay? Or sometimes I treat patients with VT, just, you know, few, maybe 1 VT, but it is so fast. Versus I see patients with lots of couplets with lots of VT, but they are so slow, like 10, I don't know, let's say 12-year-old with, you know, lots of non-sustained VT episodes, rate, let's say 135 beats per minute, suppressed with activity, monomorphic, no symptoms, echo-normal. Why would I treat this, right? So, but, you know, you have another patient having non-sustained VT, rate 260 beats per minute for 4 beats. Occasionally, that I would treat for sure, and I would be more concerned about this patient. Of course, there are other factors like whether there's any congenital heart disease, you know, ischemia, all these things. Whether there's any sign of, you know, cardiomyopathy. These are different issues, but I'm speaking in general. So you need to pay attention, couplet, VT, the rates, any RONT. You know, if you are having PVCs always coming like on the top of the T wave or in the, you know, downstroke area, this is how actually we induce, you know, arrhythmias. Like in the EP lab or in the OR, when we implant an ICD, if you want to induce actually VF, the way we induce it actually, one of the ways is by giving a little shock right on the T wave. So we don't like, you know, PVCs on the T waves. Although it's not a very clear issue. Some people do not get too much concerned about this, but it's still unclear issue, and you know, but I tend to get concerned when I see true RNT, and if I see it frequently. not rarely. Are they suppressed with sinus tachycardia? We don't want them to increase with sinus tachycardia. That's usually not a good sign. And it may even indicate like CPVT, right? Catecholaminergic polymorphic VT if the PVCs are increasing. Not always, but you know, it's not a good thing. So you may have to restrict patients' exercise and all that. But if it's suppressed with sinus tachycardia, uniform, nothing to be concerned. Sometimes, you know, like that, we don't even treat, we don't even restrict the patient. This is a 16-year-old patient. So just with this page, what are your first comments? I mean, without, I will show more pages, of course, but with what you see, just tell me a few things about what you see. Okay, triplets. What type of triplets? You know, we have to be specific, right? Triplet is true, but you know, you can also have atrial triplet, right? You should say ventricular triplets. Ventricular triplet actually is VT, by the way. Anything more than three or more, but it's not wrong to call it triplet. You can, of course, call it triplet. So we were just talking about it, right? So as Grace is saying, it's polymorphic because, you know, it's changing. So it's not actually, and it is fast, right? Not nice. Especially if you notice, it's getting faster towards and the shape is changing. We hate these things. This is how we usually end up in polymorphic VT or worse. So it looks like on the same page we see this also, right? I mean, look at this, only a short page strip, you see this. What else you can say about this page? What else? I mean, look at the top, the beat counts. What do you think about the frequency? This is a clean Holter, of course. It's not like a fresh out of a system. We always do scanning ourselves. 37% is what I'm trying to, you know, emphasize. It's very frequent. So let's look more, okay? Same patient, 16-year-old. So what do you see here? Even worse, right? So how would you call this VT? I guess polymorphic VT, right? Not really nice. Okay, let's look at another one. And that happens to be three lead I showed you, but that happens to be a 12 lead Holter. Basically showing the same thing. Look at this. What type of VT is this? What type of VT? Okay, anybody? Okay, people are maybe getting tired or what? Nobody's saying anything? Okay, just say polymorphic, yeah. But, you know, also pay attention how the axis is changing, right? It's plus to minus, like a bidirectional type appearance, right? Yes, as Fatma also said, it's bidirectional. So, but bidirectional, polymorphic, getting faster, very fast actually. Look at this interval. One box is 300 beats per minute. So, I mean, it's getting really fast. This is really not nice. Okay, like 3 beat, 4 beat, 5 beat, lots of PVCs. And that's all I want to show. Let's go back to the first page. It doesn't matter. Let's stay here. Okay, now this is this patient presenting with this. So how would you diagnose this patient? What would you do? Or, you know, what other questions you want to ask me? You know, this is the Holter. Or do you want to have more information about Holter? Anything specific? Let me tell you a few things. Echo is normal. Exercise related? No, it's not exercise related. And actually, if you see, when the patient is really slow, these things are happening. Unlike you see in CPVT, right? In CPVT, things occur with tachycardia. In this patient, no. So MRI not done, but normal. Let me tell you, it's normal. Echo normal. So with exercise, you know, it's let's say it's relatively suppressed, but you know, you still have them, but it's not exercise induced. Okay. Patient not on any medication. There's no family history. I'm responding to your questions. Let me see, did I miss anything? Hearing, I didn't get it. No other issue. This is how the patient presents with, yeah, I mean, palpitations, no syncope. I said echo-normal, I guess, right? Medication abuse, good thinking. Yeah, one of our fellows, congratulations. Yes, could be poisoning, right? No. ARVC, again, you know, of course you can think about ARVC whenever you have these abnormal, you know, unusual, I should say, PVCs or VT. Of course, it's one of the things, but echo normal, MRI normal, of course, they don't rule out. In terms of CPVT, catecholaminergic polymorphic VT, again, you know, it doesn't increase with exercise. It doesn't come out with exercise. It happens even at rest. Okay, so why bidirectional? It would be nice to know. I don't know, but it's, yeah, not nice. Okay, so is there anything that you noticed? Actually, one of you just put a comment, okay? And now I want you to pay attention to something. Look at the first PVC, okay? In a three lead, it's difficult, okay? But just pay attention to the morphology of the first PVC, okay? Look at this one, all right? Here, the single PVC, same as this one, right? So this polymorphic VT is starting, but look at the first PVC, okay? Look at like just this PVC. And then in 12 lead, what is this PVC looking like? Okay, inferior axis, right? Positive into 3 AVF. Left bundle branch block type appearance. So it's coming from right ventricle, most likely, right? And we look at the transition where the R waves pass the kind of the S waves, where the QRS really becomes positive. Actually, you see it's V4. So it looks like a typical RVOT PVC. And this is what I noticed in this Holter of this patient. And wherever I went, these are different pages, it's always the same QRS. So always the first PVC of this VT, this 37% patient, the first PVC was always the same, okay? And it was RVOT PVC. And of course, as an electrophysiologist, what would I do? I want to get rid of this PVC and see what happens, right? And that's what I did. This is the same patient's Holter, just the same day after ablation, RVOT. This was in Istanbul. I was working after many years in US. I didn't introduce myself, I guess, but anyways, you'll get to know. I was in US for many years. I was in Turkey then number of years, and now I'm in Qatar. So this is a patient from Istanbul, 0 PVC. So by just, you know, it's so important to pay attention to what you're looking at. Sometimes this happens for reasons unclear, even though there's no R-on-T. The PVC leads to this polymorphic, VT, and this patient just stayed clean after this. Interesting, right? So there's no ARVD. It's all about an RVOT PVC leading to this arrhythmia. And this patient, to my knowledge, even later didn't develop any ARVC. So, you know, when you pay attention to any Holter with PVCs, there are a number of things you want to look at. And all these questions you need to ask the answer for. You cannot just say this patient has PVCs or this patient has rare PVCs. You have to answer all these things, you know, that we just mentioned. Therefore, the assessment of PVC is really has to be detailed, especially PVC, you know, to really help. Let's do this patient. I would really try to cut it at 45 minutes. It's 2 minutes left. Let's finish with this patient because we may have started a little late anyways. I don't think we will automatically stop, right? I'm not controlling this thing, but we'll see. So 15 months post-op, so had VST operation, and this is day 10. So what do you think about this rhythm? The rate is what, 160 maybe? 170 beats per minute. And, you know, ICU shows you this ECG. Okay, 10 days after operation. All right. So few comments, SVT with retrograde P wave, right? JET, possible SVT, junctional rhythm. Interesting, JET. Okay. If somebody shows me, just for the sake of the time, most people saying JET. For the sake of the time, I'll just a little bit accelerate with my comments. First of all, post-op day 10 jet is a little bit unusual, right? That's first thing. Secondly, when somebody shows me this with this history, with no other information, my answer is white QRS tachycardia. This is white QRS, right? For a 15-month-old, it's definitely white QRS. I wouldn't say VT, I wouldn't say SVT. Yes, I know there are, most likely these are P waves, but no, it's white QRS tachycardia. I see, but most likely SVT, right? So, but I need more information. So this is the Holter of the same patient from different areas. And look at this trend. So whenever you have these type of arrhythmias, sustained or whatever, the trend is so important. Looking at the telemetry trend, looking at the Holter trend. This is Holter, but it will be the same in telemetry. So you see how fixed it is, and then there's some changes. So I'm with this yellow line, I'm focusing and seeing. So this fast area, as you see, the rate is about 170, are these areas, okay? But what I want to focus actually is at the slow area. So I put my yellow marker there and look at it. So this is that slow area. You see an irregular rhythm. So do you have any idea now about the arrhythmia? The type of arrhythmia in this patient. First of all, it's not VT, right? Because it slows down, still has the same white QRS. So it is IART, right? Intra-atrial reentry tachycardia. Some people can call it, flutter, but probably not typical flutter. Maybe yes, maybe no. For atrial tachycardia, it's a little bit fast. As you see, the rate is like 1 box, almost 300 beats per minute. So we call this intra-atrial reentry tachycardia because post-op we see these things. It wouldn't be too wrong to call it flutter, but flutter is a specific term. We like to use macro-reentrant atrial tachycardia or intra-atrial reentry tachycardia. So as you see, what you see then is actually variable conduction. Here, it conducts less through the AV node, and you're able to see the P waves. That's why I wanted to go to the slowest area. Otherwise, when I focus on the faster area, it just looks like that. I cannot just say. So what's happening actually here is one-to-one conduction of this IART. And in the slow areas, there's like 2-to-1, 3-to-1 conduction that gives you kind of irregular rate. So of course, it makes a big difference whether this patient is actually in IART or not. So it's not as simple as VT. If test why, because the management is totally different. The management is too detailed. But in summary, these patients, can be prone to thrombosis and even clots and stroke. So there's lots of things you need to consider before even stopping this, unless it's an urgent situation, right? So it's not like any other SVT. So therefore, the way you should approach is like white QRS tachycardia, most likely SVT, and then look at your rhythm in different areas, and then you'll get your answer. In this case, it's IART. It could have been, of course, jet with right bundle branch block. It could have been some other type of like AVNRT or whatever focal atrial tachycardia. All these were possibilities, but and if you are not able to see this, let's say I'm not able to see this in this telemetry, what would you do? The answer is already came from one of you. You get adenosine, right? You can do vagal adenosine. If you have atrial lead attached to the patient still at this day 10, you may not, but if you have it, you can do this. You can do transesophageal ECG. So you can do lots of things to bring it up. But adenosine would be one of them. Okay, I think 9:03. So let's conclude here. Again, I'll aim for 45 minutes every other week. Actually, for me, it's every week because every other week I do Turkish. And we will try to give you earlier notice. We kind of trying today this new platform. And you can also notify your colleagues or whoever wants to learn. I don't think we have limits with this. Several people can join as long as it's okay for their time. And I think they will be recording this to YouTube also. Again, I'd like to thank Congenital Heart Academy for sponsoring this. Okay, I think we can conclude. Thank you very much for joining. Take care. Everybody have a good day. I know people joining from different countries. Good day, good night. Have a nice week. Hope to see you later. Bye-bye.
Bye-bye, guys. Thank you, Dr. Volkan. It was amazing. And hope to see you every 2 weeks in English and every 2 weeks in Turkish, guys.
Yeah,
and this is recorded on YouTube.
Yes, if you want to learn Turkish, you're welcome to join that one also.
Thank you.
Take care. Bye-bye.
Bye.